So thank you very much, Imogen. Thank you very much, everyone, for having me here. It's like Mark, I'm a little bit nervous because I'm used to talking to doctors, and I sent my slides to Imogen and I said, look, Imogen, I don't know if I've gone, are they too bad? She goes, oh no, we share much worse than that online. Yours is a bit lightweight, really, so let's see how we go. So I'm lucky to work in Oxford, and I say lucky because Mark, myself, and a dermatologist called Richard Turner and a clinical oncologist called Amanda Salisbury all got appointed at the same time. So we had the basis of a melanoma unit from people who all start at the same time with the same ethos. And I think, as Mark says, melanoma care is coordinated care, and if you don't feel your care is coordinated, then you need to seek coordinated care. I think that is the most important thing. So I'm going to give a few handy hints because I know people coming from all over the country and all have different experiences. Am I going to next slide all of this lot? Here we go, 80%. So I was pessimistic, but then I thought I was pessimistic till I met Mark 15 years ago, because as he's explained, he was very pessimistic back then. But most melanoma is cured by surgery, which is great news. Surgical interventions for melanoma. I'm just going to go, I know that most people sitting here have had a lot of surgical intervention, but I also know that quite a lot of you are supporting people who are starting their journey. So I'm going to go through everything from the start, and I apologise if it's not of interest. So where am I pointing this thing? Anywhere? It doesn't work anywhere. Okay. So T melanoma is removing the melanoma the first stage, the excision of the melanoma, the wide excision, and the sentinel lymph node biopsy, which we will touch on later because Imogen has asked me to. So nodal surgery is what we call end surgery, and that's sort of what we call stage 3 disease. So we've got melanoma in the lymph glands, and then we've got M surgery, so melanoma that's spread outside the local region is elsewhere in the body. And then, believe it or not, surgery does work in that instance as well. So, as you know, the amount of tissue you take away depends on the depth of the primary melanoma. So here's a narrow 1 centimetre excision, but of course we can sometimes do. There we go. We can sometimes do wider excisions, and this is the first handy hint. Of course, you need your first melanoma removed by somebody who knows how to remove melanoma, because if they remove it in a cross-shaped fashion like that, then the wider excision has to be slightly more extensive than you would like. So, and that's somebody who's getting a 2 centimetre margin around their scar there. And sometimes people present with worse conditions. So this lady had the scar you can see just to the right. And by the time that had healed and she got to see me, she'd got small amounts of melanoma that was coming away from the scar. So that's half the lower leg going with a margin and a skin graft. And I've taken out all my big gory pictures, but I feel guilty about that. I'm definitely going to ramp it up for next year. So what margin should we be taking? Well, there's a lot of work on margins. And years ago, before I knew anything about melanoma, people were taking 5 centimetre margins. That's what you needed for melanoma. And then there was a great big trial comparing 1 with 3 centimetre margins. And we're now we just had some recent national guidance, which Julia will talk about. But in essence, if you've got melanoma less than about 2 millimetres in thickness that isn't ulcerated or thinner, then you take about 1 centimetre, and anything worse than that, you take 2 centimetres, sometimes going up to 3 centimetres in certain circumstances. Here we go. This is the only surgical trial you're going to get for the day, so enjoy it. This is the Mel Mart Trial. So there's a study going on that's going to eventually recruit 10,500 patients, we hope, and it's comparing basically 1 versus 2 centimetres. Do we actually need to take a 2 centimetre margin? Does it make any difference? And we won't know that for 10 or 15 or 20 years, but at least there's an effort going on around the world to find out, and most centres, Bristol here, Oxford, are part of that. What about the lymph nodes? Well, of course, the controversial, I don't know if it's controversial. Anyway, sentinel lymph node biopsy has had varied press. I have to admit to being an enthusiast of sentinel lymph node biopsy, so I couch everything I say in that. But essentially, if you think about your body as a patchwork quilt, then each patch of your skin will drain all its rubbish, so fungus, bacteria, cancer cells, to 1 or 2 lymph glands, which are basically garbage processing plants. And if you can find out which the lymph node is and take it out and analyze it, you can tell if the melanoma has spread before you can feel that it has spread. And I think 7, 8, 9 years ago, your only option was to keep going with surgery. But now, as I'll touch on lots of times, as you've heard from Mark, there's drugs and drugs and drugs that are coming online. So getting information early is a good thing, in my opinion. So here's a little melanoma cell. It goes to the sentinel node. Now, in our experience, there are 1.7 sentinel nodes. Obviously, we don't take out a 0.7 of a node, but on average, there are 1.7 sentinel nodes in each lymph node basin. And we know that the melanoma spreads to the sentinel node. It might move on, but it always stays in the sentinel node. And therefore, if we have removed it, we can tell if the melanoma has spread. So this is our experience, and it's the reason I'm putting it up is actually because this is level with international standards. So this is roughly what happens around the world in the best centres. We've now done 1,600 sentinel node procedures in Oxford, which we're analysing, and you can see the amount goes up each year. And in essence, most people who have it done are in the middle group, but you can see we're happy to do it in people with thick melanomas, and I'll explain that. 15 minutes to go. Okay. Sorry, I was just waving at me. I've now got it. So 700 people, and look, about 20% are positive. And as you can imagine, as the melanoma gets thicker, the positivity goes up. And as you can see, the sentinel node status is very important in determining what the eventual outcome is going to be. And this is also relevant in thick melanoma. And I just want you to look at the green line, because the green line could represent somebody who has a 10 millimeter thick melanoma without any ulceration. Now, but actually, if their sentinel node is negative, their melanoma behaves very much like a thinner melanoma. Whereas if you've got the red line, if you've got a thick melanoma with ulceration and a positive sentinel node, then it does behave very differently. So these are all thick melanomas, all this broad group of thick melanoma, but you can see that the outcomes are completely different depending on the sentinel node status. And this is important because the oncologist sat here will one day have a treatment that you can use in high-risk patients before anything comes back. But some of those treatments might have a few toxins associated with them. So you need to know which people it's worthwhile doing it on and which people it isn't. So this is quite important information, and there's been about 5 or 6, probably more, Mark will know, more studies all came out at the same time saying the same thing. So the future is here. We want to identify our high-risk patients, and we want to be able to use surgery to help the oncologists move forward their treatments for your benefit. We could go on and on about it. To me, the main benefit is I want to deal with melanoma in an armpit that looks like his left rather than his right. And since we've been doing sentinel lymph node biopsy, I don't see people rolling in with, melanoma hanging out of the armpit or anywhere else. We deal with it when it's small volume disease. And if you deal with it when it's small volume disease, the complication rate and ongoing problems are much less. What are the disadvantages? Well, I could go this. These are temporary disadvantages, and they're small percentages. This is the main disadvantage. If you've got it on the leg, use about a 5% chance of permanent mild leg swelling. And I've done about 300 sentinel node biopsies in people on their upper limb, and I have one man who has mild swelling of his breast that doesn't bother him. And that is the only long-term complication I can think of doing sentinel lymph node biopsy in the upper limb. And Matt Potter, who's one of my colleagues in Oxford, is about to publish the largest series of head and neck sentinel lymph node biopsy. Everyone goes, oh, you can't do it in the head and neck. And he has a complication rate at long term less than 1%. So it's a very safe technique if it's done by the right people. Survival benefit, I believe there is for certain people. I don't believe there'll ever be any conclusive evidence that proves that. So you pays your money, you takes your choice, really. So what's the point of doing surgery for melanoma that has spread beyond the lymph node basin? And a lot of people say there isn't any point. And I certainly know that because we have had people referred to us who have said there was no point in doing surgery, but they've they've come. So I think that there is a little bit of doubt elsewhere. And I think that surgery in this setting I regard it as an oncological treatment that is guided by the oncologist who is looking after the care of the patient. But it is certainly a valid and useful adjunct. So first of all, we can help with the side effects of immunotherapy. So any little cancers or things that come up as a result of the immunotherapy, we can remove those. In Oxford and other places, we collect tissue samples for the biobank. So we have a role in doing that. So these are sort of supportive things to do. We also have a role in dealing with lumps of melanoma that are causing great problems and great distress. They might cause dressing problems. They might cause actually just seeing them psychologically is upsetting. And the trouble is that I think if you ever get anything like this, make sure you get an opinion from a surgeon, because this was removed under local anaesthetic in 40 minutes with a patient awake. This was a relatively minor procedure. So things that look absolutely dreadful are not always absolutely dreadful, and they are relatively straightforward, can be relatively straightforward to remove. And it's a relevant discussion to have if you can do a straightforward surgical procedure to make somebody feel much better. Aside from the fact that you're removing a great big lump of melanoma, and as you can see from my slides, they're a lot simpler than Mark's slides, so my brain is slightly smaller. But I sort of have this feeling, if you remove this great big lump of melanoma that your body's busy trying to fight, then it lets your body fight the other stuff that's elsewhere. But that's, I'm sure that has theory somewhere. There we go. Oh, did we go too far there? There we go. So, I've really confused it now, I apologise. It's my fault. Next slide, please. So this is the whole point. We want to reduce the amount of melanoma. We want to reverse the immunosuppressive effect of having a large lump of melanoma. We can do it with less morbidity, because, of course, surgery is improving in terms of techniques. And we do it in line knowing that we're going to be using immunotherapies as well at the same time. And, of course, you can repeat your surgery. Next slide, please. So if you've got selected patients with limited sites of melanoma, you can actually consider surgery as one of the more, I hate to say the curative options, but one of the options that does have some success. And you can get complete resection at least for a period of time. Next slide, please. So this is somebody who has, for all intents and purposes, has no disease elsewhere except for this large lump melanoma here. So you can remove that with a 2 centimetre margin. You've got complete excision, local control, and we know that survival is improved by doing that. And this same exists if you've got it, next slide please, in the lung. If you've got a lung, next slide please. If you've got a lung metastases, all of this data is desperately old because it's from before immunotherapies came on. And we're never going to get surgical data like this anymore because we're always going to be using other treatments to help these patients. But it wasn't great, but if you remove that lung metastases in this old study, so 5,000 patients, you at least got a 5-year survival of 21%. Well, that's better than 0%. So surgery actually did something in those patients. Next slide, please. For brain metastases, there's various ways of removing from stereotactic surgery, using special knives to open brain surgery. And again, in people with isolated metastases in the right place, surgery is definitely an option. Next slide, please. Gastrointestinal tract, the same, so that's your guts. And again, if you have isolated lumps of melanoma in those areas, you can remove them depending on being the right sort of patient and the right picture. And next slide, please. Liver is less successful, so you can see there's 1,750 patients. They found 35 that they could consider, and they could only manage to operate on 18. But again, this is old data, but it's just a question of looking at everything and every individual and seeing what is possible. Next slide, please. And again, we're back at about 20% success rate. So isolated metastases in the spleen, adrenal glands, or pancreas, we can have some success by removing them. And these can be done laparoscopically in some cases. Next slide, please. So I just thought I'd mention this one trial, and this isn't, Mark's talking about 2,000 patients. This is 64 patients. Next slide. And basically what they did is they took people who had up to 5 metastases, and they said that could be removed surgically, and they removed those metastases, they removed those lumps, and then they compared a placebo versus a vaccine. And they found that actually the vaccine was worse than the placebo. But the important thing is look at the survival at 5 years. So for people with metastatic skin melanoma, if you removed it, you got around about a 40 to 50% survival at 5 years. But even people with lung or brain type melanoma, you could get, just by removing it, you could get a reasonable survival picture, which doesn't, I'm not sitting here saying do surgery. What I'm saying is that if you use this with everything else you've got in a coordinated fashion, you can pull these things all together. Next slide, please. But once you start getting more lumps of melanoma, it's less successful. Next slide, please. So there is rationale for doing surgery in stage 4 disease. It has to be a coordinated approach. It is less expensive than some of the drugs, and some of the techniques are improving. And I think if you've got few sites, 1, 2, maybe 3, and they're isolated lumps, then using surgery in that role in combination with immunotherapy after immunotherapies is a good thing to do. Next slide, please. So in summary, as Mark so kindly said, and I'm going to bump up my figures to 85%. So in summary, 85% of melanoma is cured by surgery. It has roles both in cure and investigation. I think it has a very big role in reduction of tumour burden. And in the stage 4 disease, as we discussed, this has to be part of an oncological management, but it is a very useful adjunct to all of the very exciting immunotherapies that are coming along. Next slide, please. Thank you very much.